Hi, everybody. My name is Navi. For those of you that don't know me, I'm a cohort 4 graduate. I graduated with a PhD at Wayne State University this May of 2021. And I'm also a nurse practitioner that works in an interventional pain clinic in Ann Arbor, Michigan. And, I would have loved to have been with you all today. I really, really was looking forward to this conference, but I thought that kids under 5 could get their vaccine by now, but that still is not the case. So I just wanted to play it safe as I have a 2-year-old and 7-month-old twin girls. So I hope you all are having a great time, and I really would have loved to have been there. So I normally take about a 60-minute talk for this, but I'm going to condense it in 10 minutes. So a little bit about my research is that I looked at factors that affect adequate analgesia in African Americans with cancer pain. I'd like to first off, thank my committee because they were, essential in me getting this done in such a short amount of time. Dr. April Vallerhand, who is on the far left, she is my advisor. I also work with Dr. Ramona Bankert, our statistician, Dr. Thomas Templin, and our partner in the School of Medicine Cancer Research, Dr. Haley Thompson. So disparities with African Americans with cancer pain is no new issue. It has been going on for several years in regards to non-cancer and cancer pain. African Americans historically have reported greater pain, have had less function, and other studies have shown that African Americans are less likely to get their pain scores even recorded. And there still seems to be a attitude that exists that African Americans just don't feel pain as opposed to other racial groups. This has been historically the case for many years. So for my specific aims, I wanted to specifically figure out what exactly is, happening here with these disparities. These still continue on for been going on for many, many years, but what exactly are we doing about it? And so I wanted to first look at our patient population, which was 302 African Americans with cancer pain in an urban setting here in Michigan. And I looked at the pain management index, which I'm going to show on the next slide, which basically calculates the adequacy of analgesia. So basically, for the given reported pain score that you are reporting, did you just get the right class of drug for that pain? So not looking at frequency, not looking at dosing. I just want to know, did you get even the right class of drug for the pain score that you reported? My hypothesis was that, hey, if you say you have higher pain, then you will at least be up titrated and get a stronger medication. And for my second aim, then, I wanted to again figure out why this is still happening. I was kind of, not happy that we're just publishing that disparities exist. But what are we doing about it? Why is this happening? Is anybody trying to figure out why this is happening? It's not enough to just highlight that a problem exists. We need to figure out why this is happening and then make an intervention to kind of reduce this or stop this disparity from, continuing to happen decade after decade. So here is my adequacy of analgesia, the pain management index. And what I am doing here is basically, if you look at this thing, this is considered no drugs, and this is considered no pain. So on this axis, it's no drugs is basically you're not getting any medication whatsoever. Non-opioids are, you're getting your Tylenol, your Motrin. Weak opioids are those combo drugs such as your Norcos or your Percocets. The strong opioids are indeed like the pure morphine and the pure fentanyl. And remember, this tool is for cancer pain. Okay, and then on this axis, we just have your reported pain scores, so 0 to 10. So you have no pain, you're 0. And if you're between 1 and 3, you're considered mild, 4 to 7, moderate, and 8 to 10 is severe. So if you are saying I have a pain score of no pain and you're not getting any drug, you basically get a pain score of a 0, or a PMI of 0. And if you were, say, reporting, okay, your pain is a 10 out of 10 and you're getting absolutely nothing, then that would be considered a score of a -3. So negative scores are considered inadequate pain management. And then a 0 or positive score is at least considered that you have adequate analgesia. So I basically calculated the pain management index for all 302 African Americans with cancer pain. And the results were kind of shocking, actually. So in this sample, 40%. Okay, remember this is cancer pain. 40% of African Americans with cancer pain did not even receive the right classification of drug for the reported pain. So I'm not looking at frequency. Some patients, they're getting it, just make it BID, make it TID. No, they did not even get the right class of drug for the reported pain score. And that was quite alarming because, this is a well-known, urban cancer center in Michigan. And so just to have 40% was quite alarming and quite shocking that this disparity still continues well into, even in today's times. And then what I wanted to figure out after that is, now that we know that these patients are not getting adequate analgesia, what is the reasoning? What is actually happening? So I looked at age, I looked at gender, education, employment, metastasis, and having a support system. And the only factor that made a difference was metastasis. Metastasis was significantly had a significant relationship for adequate analgesia, which then made me have another question in my head. Is there a disparity within cancer itself? Why is it that patients that had metastatic disease were able to get adequate analgesia, but patients who still had cancer but not necessarily metastatic disease, why is it that they did not have, also receive adequate analgesia? So it makes sense, if you have metastasis and you're having, more organ involvement, and you are therefore going to get more analgesia. But I still question myself, that still doesn't mean that patients who have cancer but not metastasis, they should still also have adequate analgesia. So it was still kind of concerning for me. But no other factor I found had a significant relationship with adequate analgesia. And then my initial hypothesis, at least I was happy to see that was indeed the case. So my hypothesis was that if you did report a higher pain score, so if your pain score did go up, then you did get a stronger analgesic drug. So that was at least something I was very happy to see, that at least patients report higher pain would get a stronger analgesic. So the key takeaways from this study is, again, 40% of patients did not receive adequate analgesia by just their drug class alone. Patients with metastatic disease were more likely to receive adequate analgesia than those patients who did not have metastatic disease. So when it comes to clinical practice, we have to look at the pain management index kind of in a broader lens. Because pain management index is just looking at the drug class alone, I wanted to figure out if we're able to modify the pain management index to see if we're able to look at, the dosing as well as the strength. So, just because you have a Norco, it could be a Norco 5, Norco 7, Norco 10, and also like the dosing. Is it, once a day, twice a day, 3 times a day? The pain management index kind of falls short when it just comes at the drug class. And since this patient population has well-known, documented history of having disparities in pain management, I really feel that providers need to do a self-risk assessment when they are caring for these patients. It could be implicit bias, it could be explicit bias, but we really need to make a well-known risk assessment when we're taking care of these patients that, hey, this patient population group has had disparities with pain management, and, I want to make sure that, they are well taken care for. And in terms of research, I think future studies need to look at, repeat the study with different patient populations. I want to know, with the Asian population, with the Hispanic population, and with an all Caucasian population, is there any factor that led to having adequate analgesia? Was it age, gender, or anything? Because this study did not find that for African American pain, so I was interested to see if it would be replicated in any other study. I wanted to figure out why is it that metastatic disease led to having adequate analgesia, but cancer alone did not. And future research should also be done to improve the pain management index to make sure that it has those other lens by looking at the dosing as well as the strength of the drug. And that is about all I have in terms of time. So I'd love, if anyone has any questions, please email me. And I hope you all are having a great time down there. And RWJ has been a great part of my life, and I've created long-term friendships from this program. So this really was a wonderful experience. And I'd like to thank the RWJ Foundation, all my fellow um, friends in the cohort 4, as well as just everyone who's been, we've all been supportive of each other. And so I'm just really blessed and thankful to be a part of this wonderful organization. All right, thanks everyone. I hope you all message me if you have any questions. Thanks. Bye bye.